Well, thank you for the opportunity to be here. I like the graph that was just shown by Raquel because I was in South America very early with the introduction of the BD Max. And so I feel very honored to be invited to come back now for your presentation that we have today. And hopefully what I can do is share some insights with you. May I see the next slide, please? So when I was thinking about a topic for this presentation, I was struck by the fact that I think most people don't appreciate how molecular diagnostics fit into the microbiology community and diagnostic tests that we perform. So I selected this title to illustrate the fact that whether we're talking about doing cultures or microbial identification or antibiotic susceptibility testing or molecular diagnostics, all of this is microbiology. And so what I'm going to try to do is to show in this presentation exactly what I'm referring to when I talk about microbiology and diagnostics as being the same. May I have the next slide, please? All right. Now, I know not everybody comes from a microbiology laboratory that's performing the molecular test. And so I have to say for the microbiologists, this will seem self-evident. But for the entire community, I'd like to say that when we think about microbiology in a historical sense, we think about doing cultures on solid media, like the examples I have in the upper left-hand corner, or doing gram stains to detect organisms in the lower left-hand corner. We think about doing biochemical tests, and I give a couple of examples in the upper right-hand corner. We think about doing susceptibility testing by diffusion originally. And we think about immunoassays. And all of this is performed in a very crowded laboratory space. And that is really the history of what we think about when we talk about microbiology. May I see the next slide, please? So what we see today when we walk into the microbiology laboratory is really a very different picture from what I just showed. We still do gram stains, we still do cultures, we still do immunoassays and susceptibility tests and identification tests. But the platforms for many of these tests are quite different. We see a great deal of automation that's being introduced into the laboratory. It started initially with doing automation with blood cultures, and then we saw with susceptibility tests and identification tests, automated platforms for performing those tests. We now see that the entire laboratory can be automated. In the lower right-hand corner, I show an example of an automated laboratory with a BD Keystra system. But in the center really illustrates what I think is an important point. And that is, as we think about microbiology and we think about the changes in microbiology, we have to look at how molecular diagnostics has been really a leader in the changes that we see today. So may I see the next slide, please? When we think about molecular diagnostics, we also have to think about the fact that these tests bridge from the simplest point of care test to the most complex high throughput instruments. And so if we look at what BD has been able to develop and what is bringing onto the market, today we're talking about the BD Max, which is an excellent platform for small to mid-volume testing in a centralized laboratory facility. But within the next year or two, you're going to see a molecular point of care test that was acquired by BD, the NatDx test. and that'll be used for testing at the patient's bedside or where the patient comes into the medical community. We also see today these very high complex, high throughput centralized testing with something like the BD core. When we think about the menu of tests, it is equally broad. What we see is tests such as for women's health and sexually transmitted diseases. I give 4 examples here: the test for group B strep, the test for Chlamydia, GC, and Trichomonas, the human papillomavirus test, and the vaginal panel. I'm going to go through each of these, and I recognize that not everybody would consider using each of these tests, but the point I want to make today is that all of these tests get integrated into what we do in a microbiology laboratory, and so there's a role for all of these. We can look at the BD Max test for hospital-acquired infections, such as with methicillin-resistant Staph Aureus, or the Staph SR test, or the checkpoint test for carbipinamases. We can look at a menu of different enteric tests, such as one for C. difficile, 2 different panels, one for bacterial enterics and the other for extended bacterioenterics. We can see a viral enteric panel and a parasite enteric panel. So a whole spectrum of panels that allow you to, with very much of a focus on what's potentially causing the enteric disease, to be able to do that diagnosis. And then we see respiratory panels, and maybe the very first one that you saw was a test for the COVID-19 virus. We also have one that we've recently introduced, looking for that coronavirus as well as influenza and RSV in a single test. And then also last year, we introduced a multi-drug resistant test for Mycobacterium tuberculosis. So let me go through each of these and try to illustrate why I think this is very important to appreciate the fact that this is part of microbiology as we think about it today. May I see the next slide, please? So molecular tests such as nucleic acid amplification tests by PCR are most useful for certain categories of diagnostics. The first would be organisms that are difficult to grow in culture. And maybe the most important ones to think about, the ones where it's most obvious, is viruses. Most laboratories don't have the cell lines or the expertise to be able to grow viruses. And so for a diagnostic test, like the molecular test on the MAX platform, this becomes quite important. Of the 14 tests that I just mentioned, 5 of those include viruses as part of the menu of pathogens that are detected. So we can see that for almost half of the molecular tests that we offer on the MAX platform, we're looking for viruses. We also have other organisms that are difficult to grow. Chlamydia Trichomonas is maybe a very good example. It is grown much like a virus, but very few laboratories today can grow chlamydia. And that's why the molecular test becomes quite important. And in fact, that was one of the very first molecular tests that was developed probably in the early 1990s is when we first started using molecular tests to diagnose chlamydia infections. We have a number of parasites that are difficult to either to grow or to see microscopically. And so we have a parasite enteric panel, as well as a test for Trichomonas vaginalis. And then finally, we have a test for vaginal anaerobes. And many of these anaerobes actually cannot be grown in culture. And so without this test, we wouldn't be able to make an accurate diagnosis. And I'll illustrate that in a few minutes with some examples. Molecular tests are also useful for detecting slow-growing organisms, and maybe the best example would be Mycobacterium tuberculosis. Yes, we can grow the organism, but it generally takes anywhere from 3 to 8 weeks before we have a culture that's positive. and then a number of weeks after that to be able to specifically identify the organism and perform antimicrobial susceptibility tests. So a molecular diagnostic test can do that in 2 to 3 hours rather than 2 to 3 months. Very important to think about. Molecular diagnostics have also been used to detect the genes that encode for toxins or the genes that encode for antibiotic resistance. And again, one of the very first tests that was introduced in the clinical laboratory was to be able to detect the MECA gene that's responsible for methicillin resistance in Staph aureus. More recently, we've seen tests such as the checkpoint CPO test that detect the carbipinamase genes. In other words, the genes that are responsible for resistance to carbipinams and all of the other beta-lactam antibiotics. Again, very critical for patient management. We see tests where a rapid result is important. The test for Mrsa, if we're screening patients before they're put into the general hospital population, that test becomes quite critical for managing those patients. The same thing is looking for resistance to the carbipinams and the other beta-lactam antibiotics. So these tests become quite important for the management of infections. And finally, we have a variety of tests for syndromic panels. Now, there's two approaches to this. You can develop a highly multiplex panel that can detect all the parasites and bacteria and viruses that are responsible for a specific infection, let's say a respiratory infection or an enteric infection. Or maybe a more focused approach would be to say, in the case of enteric infections, we can look at bacterial and viruses as having the same epidemiology. So we would test for those together, whereas the parasites have really a very different epidemiology. It's a different patient population. So those should be separate and tested separately. Two different approaches. We've elected to use targeted syndromic panels. And again, I'll talk about that in a second. So maybe to summarize the point that I'm trying to make here is that when we think about microbiology testing, molecular diagnostics are an integral part of that and represent as many as half of all tests that are now being performed in the modern clinical microbiology laboratory. So it's not a separate diagnostic, it's integrated into microbiology. May I see the next slide, please? So what I would like to do now, excuse me, is to walk. Fortunately, I've been immunized, so I'm not concerned about getting the virus, but unfortunately, I also have some allergies this time of the year, so you have to excuse me if periodically I start coughing. I apologize to our group here. What I'd like to do is to talk about some of the different assays that have been developed for the BD Max. And again, I'm going to focus primarily, with one exception, on the BD Max for my comments that I'm making here. If we look at tests for women's health, as well as for sexually transmitted diseases, I'm going to talk about 4 different assays here. I'm going to give you an overview of the assays, and then I've pulled one representative article that's been recently published relevant to each of these assays to try to illustrate the value of these tests. We can start off with group B Streptococci. This test is important for the rapid detection of pregnant women who have been colonized with this organism. And the goal is to be able to diagnose colonization with group B Streptococcus immediately before the pregnant woman delivers her baby. And the goal then is to prevent the neonatal sepsis and meningitis. The second test that I want to talk about will be Chlamydia Trichomonas, Neisseria gonorrhea, and Trichomonas vaginalis. three very important sexually transmitted pathogens. We tend to recognize, I think very early on, recognized the role of chlamydia and Neisseria in sexually transmitted diseases. I think it's only been in recent years that we've appreciated how important it is to recognize the role of Trichomonas vaginalis. And so this test combines detection of all three of these pathogens. And I'll say the reason molecular test is important is because, as I've illustrated, chlamydia is not grown in most laboratories. Neisseria is a very fragile organism, so if the specimen is mishandled, the culture will be negative. And Trichomonas is either where we attempt to grow it, which would take a day or longer, or we attempt to see it by microscopy, which is relatively insensitive and requires technical expertise to recognize this particular parasitic flagellate. So again, we can see where molecular diagnostics offer an important advantage for those three pathogens. The vaginal panel is quite interesting because it's the first microbiome assay that was developed as a diagnostic tool. We know that vaginitis can be caused by yeast, such as Candida albicans. It can be caused by Trichomonas, or it can be caused by bacteria. The interesting aspect of the bacterial pathogen is not a single organism. It's not like detecting Neisseria gonorrhea or Chlamydia Trichomonas. With vaginal disease caused by bacteria, what occurs is there's a shift in the normal population of bacteria in the vagina. Normally, the vagina is acidic because it's populated with lactobacilli, and almost exclusively with lactobacilli. And what happens in vaginosis that's caused by bacteria, you see a decrease in important lactobacilli that maintain the balance of the bacterial population, and a proliferation of anaerobes. Now, interestingly, those anaerobes are very difficult or virtually impossible to grow. So the only way that you can make an accurate diagnosis is either by a molecular test, which is the most precise, looking for this shift in the population, or we do it by microscopy, which is relatively insensitive and nonspecific. So again, molecular diagnosis plays an important role here that really is not replaced by any other diagnostic that we have. And the last test that I'll mention in this context is that for human papillomavirus, or HPV. And the thing that we've learned today is that virtually all cervical cancer is caused by this virus. Now, I'll share a story with you. I've been involved in microbiology for almost 50 years. And when I was in graduate school, many years ago now, I was studying a virus that I was able to demonstrate caused cancer. This was cancer in a guinea pig, but it was cancer. The interesting thing, that was the second virus that had been shown to cause cancer. Before that, only one virus had been shown to cause cancer, and that was in chickens. So maybe I was way ahead of the curve, I don't know. But today we know there's a number of bacteria and viruses that cause cancer. But maybe, in my mind, the most important one, and the one we really can address successfully, is HPV. Because we know it causes cervical cancer, virtually all the cervical cancer. It also causes throat cancer and anorectal cancer. So a very important virus. And the Unclarity part of this assay means that we can genotype the virus and be able to say, is this a strain of HPV associated with malignancy, or is this one associated with simple colonization and not of concern? And so not only can we detect the pathogen, the virus here, but we can also assess the risk of cancer by this particular assay. So I would look at maybe the most impactful of all the assays that we have created is the HPV Unclarity genotype assay. Now, let me just share a couple of articles with you to illustrate the importance of each of these. May I see the next slide, please? So I'll start off with the MAX group B Strep assay. In this particular study, and all the studies that I'm going to present with, I think only one exception, they've all been published within the last year or so. This particular assay was just published, and they looked at 250 preterm women for colonization with group B Streptococcus. And they compared the molecular test with a historical traditional culture. Now, again, what you want to do is be able to test a woman immediately before she's going to deliver so you can provide antibiotic therapy to decrease her colonization. You don't want to have a significant delay. But with culture, what happens is that you first have to take the specimen, put it into an enrichment broth, and incubate it overnight. After overnight incubation, you take the broth, subculture it on the specific selective media for group B strep, and incubate it for 1 to 2 more days. So it can take 2 or more days before you've detected the bacteria and actually been able to identify it. Again, with a PCR test, you have the results within a couple of hours. So you would say, well, that's wonderful because it's going to be more rapid than what we have with our traditional method. But I think this study actually illustrates something even more important. With culture using very specific techniques, they found that 16.4% of the women were colonized with group B strep. Very interestingly, with the MAX test, they had almost a 50% increase. 23% of the women were found to be colonized. In other words, with culture, we're missing a significant number of the women that in fact are colonized with this important pathogen. They also looked at 2 other tests that they developed in their laboratory and found they were less sensitive than the MAX. And I think that again illustrates another important point. Not all PCR tests are created equal. It really depends on the assay design and the targets that you're looking for in order to determine if in fact the test is worthwhile. So for group B strep, very important. Next slide, please. This is a study that looked at the assay for Chlamydia, Neisseria gonorrhea, and Trichomonas. And in this case, it's a little bit different. What I decided not to compare MAX assays with somebody else's assays, but to look at one very important point. If you didn't have a molecular assay, what is the physician going to miss? In other words, if you don't suspect that these pathogens are present, if you don't suspect the pathogens are present, what in fact do you miss by not having the assay? So in this case, they were looking at patients where the diagnosis was that the patient had either a bacterial vaginosis or candidiasis. And they took those patients where they didn't suspect Neisseria, Chlamydia, or Trichomonas. They took those patients and asked the question, what would we have missed? And it turns out that there's a significant number of patients that were positive for chlamydia. For those who were seen in a non-STD clinic, just a regular clinic, chlamydia was present in about 5% of the patients. When you looked at patients that were seen in an STD clinic, that number increased to almost 12%. With Neisseria gonorrhea, there was roughly a 4-fold increase in positives between the non-STD and the STD clinics. And with Trichomonas, they saw a very high number of patients that did not have bacterial vaginosis or candidiasis, but rather had a Trichomonas infection. So I think again, what this gives you in terms of diagnostics is the opportunity to expand your capabilities of providing an accurate diagnosis, in this case, for women with vaginal disease. Next slide, please. So to look at the vaginal panel, it turns out that this also is quite important. This was a study that actually compared the accuracy of the vaginal panel, let me rephrase that, where it assessed the accuracy of physician diagnosis of the cause of vaginitis. And they used the reference method and they used the molecular method as the gold standards. Now, the results of the reference laboratory and the MAX assay were virtually identical. And that's the graph that's on the table that's on the left-hand side. The table on the right-hand side, I apologize because with this magnification, I don't think you can read it. Let me just provide a summary of that. And again, what they're looking at is how accurate was a physician diagnosis of the cause of vaginal infections. When the patient had bacterial vaginosis, as determined by the MAX assay and the reference laboratory procedure, what they found was roughly 1/3 of the patients were inappropriately treated. Patients that had yeast vaginitis, 60% of the patients were inappropriately treated. And patients with Trichomonas infections, based on clinical diagnosis, 71% of the patients were inappropriately treated. In other words, if we rely specifically on physician diagnosis, the vast majority of patients are not going to be treated properly. And sort of the corollary to that, if you looked at patients that turned out not to have a vaginal infection, and there was 120 patients in this particular study that did not have, there was 41 patients out of the 120 patients that were tested. 41 patients did not have a vaginal infection. 34% of those were still treated with antibiotics inappropriately. So what you see is that the BD vaginal panel can actually help guide physicians in the management of their patients. And I think that most people familiar with this disease recognize that the problem with physician diagnosis is that we have many patients returning for a repeat diagnostic test, repeat treatment that's ineffective. And so a very specific diagnosis becomes quite important. May I see the next slide? The last one is the Unclarity Hpv test. And just to summarize this one very, very briefly, if you look at the overall agreement between doing cytology, and this is really reference cytology, we had a panel of experts that looked at literally thousands of patients where this test was performed. And the panel of experts had to come to a consensus for each patient, whether or not they had risk of developing abnormal cytology. The overall agreement was greater than 98% for all of these patients. So very high agreement for the Unclarity Hpv test with what's normally done by really a very rigorous cytological examination. May I see the next slide, please? So what I presented here are 5 different enteric assays that have been developed for the BD MAX. The first one was the Clostridium difficile test. Then we see a variety of different types of tests that were developed to detect enteric disease. We have I would call it the routine bacterial panel, which would be Salmonella, Shigella, Campylobacter, and Chicotoxin-producing E. coli. We see the extended bacterial panel for less common bacterial pathogens like Yersinia, enterotoxigenic E. coli, Plesiomonas, and Vibrio. We have the Max Enteric Parasite Panel, Entamoeba histolytica, Giardia lamblia, and Cryptosporidium, and the Max Enteric Viral Panel, Norovirus, Rotavirus, Sapovirus, Astrovirus, and Adenovirus. Now, again, I think as we look at these panels, we have to think about what is going to be most useful in your community. And I would think, obviously, C. difficile is important because it's responsible for a significant number of serious disease in all hospitals. The enteric bacterial panel, the routine one, really is going to include enteric bacterial pathogens that are seen in virtually all hospitals. The extended bacterial panel, you have to assess how common are these in your particular hospital setting. Vibrio is more common, obviously, in areas where they're in contact with C. Enterotoxigenic E. coli is actually fairly common in South America, so it does become a consideration. In contrast, Yersinia may be less important and Plesiomonas may be less important. As you look at the enteric parasite panel, what are listed here are the three very common parasites. But again, in Latin America, that may not be comprehensive enough. And so you have to make decisions about how you could use these in your particular setting. And the enteric viral panel, I think, is maybe the most important because, again, historically, we haven't been able to make this diagnosis because we didn't have tools to be able to isolate the majority of these virus pathogens. Now, you could say that, well, for the most part, we're not going to be able to treat these infections. I think we have to look at it from a different perspective. And that is, you have a patient who's been hospitalized with severe diarrhea. You want to be able to make the diagnosis so you can then manage the patient themselves. And whether that's symptomatic management or using antibiotics, such as to treat some of the bacterial pathogens, or antiparasitics for the parasitic pathogens, you have to make those decisions. And in the case of the enteric viral panel, it's quite useful because it's going to be able to give you a very specific diagnosis and say, for the most part, we don't have to treat these patients with antibiotics, but rather we treat them symptomatically. Let me illustrate some of these assays in the next couple of slides. Next slide. So again, what I'm doing is not really looking at comparing one type of assay or another type of assay, but really looking at how these assays fit into the diagnostic scheme for the laboratory. Now, in this particular study, they evaluated 2,500 pediatric and adult patients over a 5-year period of time. And what they found was the test was highly sensitive and highly specific, virtually 100% sensitive and specific. I have in this slide and the next couple of slides, I share with you the positive predictive value of a test, that is, how often is a positive test accurate, and the negative predictive value, how often is the test negative. Those calculations are based on prevalence. And so in diseases where the prevalence is very low, I think they can be misleading. I'm sharing the numbers with you in these slides just so you see them because that's fairly commonly done. But what I ask you to do is focus on sensitivity and specificity. And in this particular test for C. diff, it turns out to be highly sensitive and specific. Next slide. This is an evaluation that was performed of the enteric bacterial panel. And again, if you look at sensitivity and specificity, I'll point out that for Campylobacter and for Shigella, the sensitivity was quite high and quite specific. It actually turns out that the enteric bacterial panel molecular test is more sensitive than culture for those two groups of organisms, for Campylobacter and for Shigella. The sensitivity for Salmonella was a little bit less, it was 87%, and for Shigatoxin producing E. coli, it was 80%. Specificity, that is, the value of a negative test, was quite high for both of these, for all of these 4 pathogens. Next slide. We see the same data for the extended bacterial enteric panel. And again, here sensitivity and specificity was virtually 100% for Vibrio, Papillomavirus, Yersinia, and the enterotoxigenic E. coli. And again, for many laboratories, they either are unable to be able to identify these organisms, or they're very expensive to be able to do that. That is, as an example, with Vibrio, you have to use highly selective media in order to detect that particular organism. And the enterotoxigenic E. coli, the alternative test is immunoassays, which is not particularly sensitive. So I think as we look at this particular panel, it fits an important niche where we can diagnose pathogens that aren't commonly recognized in the laboratory. Next slide. The viral enteric panel, again, has very high sensitivity and specificity. The one where the sensitivity falls off a bit is Sapovirus, where the sensitivity is 85%. It causes a disease very similar to norovirus. They're very closely related. But the frequency that we see Sapovirus is relatively uncommon. So I'm not sure if that sensitivity is a major issue. And frankly, molecular tests are the only test available for detecting that organism, as well as some of the others listed in this slide. I will also point out that as you look at the sensitivity of other molecular assays for Sapovirus, it is about the same level of sensitivity or less. And I think it's because there's a number of genotypes of Sapovirus that exist. And so we don't do as good a job as we would like detecting all those different genotypes. May I have the next slide, please? This one is the last one I'll discuss here, and that's the Parasite enteric panel. And again, very high sensitivity and specificity. And again, as I said, I think you have to assess how would you use this particular test. If these are the most common enteric pathogens that you see, you could screen patients very quickly with this particular assay. If others are much more common, then you might decide that this may not be as useful for you. And again, that's an individual decision at your institutions. May I see the next slide, please? So this slide, what I want to do is summarize hospital-acquired infections. We have Mrsa test, we have Staph SR test, and we have the checkpoint CPO assay. What I'd like to do is, why don't we go to the next slide, and I'll illustrate one important thing, that this exists both for the Mrsa XT assay as well as the Staph SR assay. And that is, it's a very complex test that may not be appreciated. As you look at this diagram, and on the right-hand side in yellow, you see what's labeled ORFX. And that's a specific gene for the presence of Staph aureus. So if you see that gene present, you know that the organism is Staph aureus. In purple, we see the SCC MIC cassette, and that cassette includes the MIC-A gene. And so we target that MIC-A gene. And if that's present, that also is indicative that the organism is methicillin resistant. And where I have the red circle and arrow is the junction region between the cassette and the Staph aureus gene. And what you see in that junction region then is the MIC-A gene is associated with the Staph aureus gene. So if you have a positive reaction in all 3 sections, in the ORFX, in the junction region, and in MIC-A, then you know that organism is methicillin-resistant Staph aureus. If you don't have a positive reaction with MEK-A, but you have a positive junction region and Staph aureus gene, that's called the dropout mutant. It's susceptible to methicillin, and this test can detect that. And then finally, if you don't have the cassette or that junction region, you just have the Staph aureus marker, then you know that also is a methicillin susceptible Staph aureus. And I wanted to illustrate the complexity of developing assays for what maybe would seem to be a relatively straightforward test. That's not the case here. You may see the next slide. In the next slide, it is maybe a little bit more direct, because what we're asking is, does the bacteria carry a gene for carbapenem resistance? And in this particular study, or this particular assay, we actually detect the 5 most common carbapenemase genes. And this particular assay showed that our test, the CPO test that was developed for us by Checkpoint, has a very high sensitivity and specificity, 97 to 98%. So a very rapid, important assay to detect carbapenem resistance, which represents a complex challenge for the management of these patients. May I see the next slide, please? So I'm going to conclude with a series of assays for respiratory tests. I'll show 2 assays that BD developed for the SARS coronavirus 2. The first is a test specifically for that, and that was the first one that we introduced. And that was introduced probably around April of last year, so almost roughly a year ago. Excuse me. And then more recently, we combined that test with tests for detecting influenza, both influenza A and influenza B. There are 2 other tests that have been developed for the BD Max platform, the BioSure test. One is for flu AB and RSV, and the other is for flu AB, RSV, and the SARS coronavirus. So very complex assays, again, for the Max platform. And then the last assay is the BD Max assay for multi-drug resistant Mycobacterium tuberculosis. And this particular assay detects resistance to both rifampin as well as isoniazid. Very important, because you can't measure one and assume that if it's susceptible to one drug, it's susceptible to both. We see anywhere from 10 to 20% of the susceptible strains to, let's say, isoniazid will also be rifampin resistant. Next slide, please. What I wanted to show here, and this is the only slide where I actually do a direct comparison, where we look at the performance of the Max SARS coronavirus 2 assay against the Cepheid Gene Expert assay. And essentially, they're identical in terms of performance. We hear a great deal about the Cepheid assay being quite sensitive. It turns out that in terms of performance, their sensitivity and specificity is between 97 and 98%. So again, highly sensitive and specific. May I see the next slide, please? And the last slide that I wanted to show is the performance that's been documented for the Max MDR MTB assay. This was data that was published by Shaw in Clinical Infectious Diseases last year. They evaluated the performance of this assay with more than 1,000 patients with suspected tuberculosis. The patients that had culture confirmed Mycobacterium tuberculosis infection, we see that the test had a sensitivity of 93% and a specificity of 97%. When we looked at patients that had positive acid-fast smear, the sensitivity was 100%, and with smear negative patients, it was 81%. we expect that the sensitivity with the smear negative specimens would be lower because we have fewer organisms that are present in those particular specimens. And again, that's been seen with other molecular tests used for the diagnosis of Mycobacterium tuberculosis. The sensitivity and specificity of the rifampin resistance test versus phenotypic test is very high, greater than 90, 95%. And the same with INH resistance. Sensitivity is 82%, specificity is 100%. I actually will make a comment here on the sensitivity with the phenotypic test for INH resistance, because this test, according to UCAS standards that have been recently published, needs to be adjusted downward to be able to detect more positive, the presence of resistance genes more accurately in INH-resistant organisms. So again, a challenge that we have trying to identify what the gold standard is. I think most people are coming to the conclusion that the molecular test, or maybe a more appropriate test than the phenotypic test, certainly they offer the advantage of rapid diagnosis and detection of resistance. I believe that's my last slide. Can we go to the next one? Yes. What I wanted to do in this presentation is to illustrate with the variety of tests that are available for the MACs to appreciate the fact that molecular testing is not in a small niche in the laboratory or in some separate lab space. In fact, it's a very important component of what we refer to as microbiology testing. So for the community, I welcome the formation and the interactions that you can have. I also encourage you to really look at how you can become more integrated in all the aspects of clinical microbiology, because molecular diagnostics, in my opinion, is a very important component of that. So with that, I'd like to thank you for the opportunity to speak to this group. I'm sorry that we can't be present in person, but maybe next year at this time, that'll be the case. So again, thank you very much.
Muchas gracias, excelente, doctor Murray. Excelente, excelente presentación, gracias. Y ojalá que la próxima sea presencial, sinceramente. Bueno, ahora dejamos este espacio para preguntas. Vi que había una pregunta escrita, la voy a leer. A ver, aquí está. La pregunta la hace Flavia Malfa y dice, hola, ¿el panel de clamidia y neisseria sirve para muestras de hombres? Gracias. Bueno, no sé si la quiere contestar usted, doctor.
I'm sorry, repeat that question, please.
No problem. Dice, ¿el panel de clamidia y neisseria?
Yes, yes.
¿No es cierto? Sí. ¿El panel de clamidia y neisseria sirve para muestras de hombres? Gracias. ¿Lo quiere contestar usted?
Yes, yes. So you can use either urethral specimens or urine specimens for that particular assay.
Correcto, sí. Y después vi que había una mano levantada. Creo que el doctor Hugo Pagela había levantado la mano. No sé si sigue, no puedo ver acá si sigue levantada. ¿Podrían darle el micrófono al doctor, por favor? El doctor Hugo Pagela. Doctor, ¿quiere hacer la pregunta? Tiene que activar su micrófono. A ver si se escucha. Bueno, mientras tanto, aquí hay otra pregunta. No, aquí hay un comentario. Excelente la presentación de Soledad Zárate. Dada la alta resistencia a los nuevos antimicrobianos, ¿Se piensa en la realización de un panel que contenga detección de BLE?
So we have internally, we have a number of discussions about future panels. And from my perspective, I think a very important panel would be one that has a series of antibiotic resistance markers so that it can be more broadly used to be able to identify antibiotic resistance. So it's in discussion. It's not in development right now. But the hope is that the next generation of panels that we develop will include one with more resistance markers.
Yo tengo una pregunta, doctor, también. Hace muchos años, la microbiología, tal como la vemos hoy, era inimaginable. Imaginar que podíamos detectar un microorganismo en cuestión de horas o en cuestión de minutos no estaba en nuestro scope, nuestro objetivo. A mí me gustaría saber cómo se imagina usted el futuro del futuro. O sea, ¿qué podría venir más que esto? ¿Qué más podemos querer los microbiólogos?
So that's really very interesting because unfortunately, maybe fortunately, I've been doing this for many years and I've been able to actually watch all those changes occurred. Where are we going in the future? I think that what we're going to see is molecular diagnostics is going to become more and more important. I'm not one that's going to say that we will eliminate culture. I don't believe that'll occur. I think it'll be much like the theme I tried to develop, that we'll have both. We'll have cultures as we know them, and maybe better, but we'll also be able to do molecular diagnostics and do things we weren't able to do before. It's interesting that if we look at multiplex tests, they're being developed now. So let's say I have a patient that has a respiratory infection. We'll have these very complex multiplex tests that can detect what we think are all the pathogens. They have advantages and disadvantages. Obviously, the cost is a problem, but I think cost will go down. I think the challenge there, though, is sometimes we have too much information. And let me try to think. When we think about, I'll use the example of Mrsa. We have to look for Mrsa in a very specific situation to be able to say this is important. If you look for that in every single specimen, it's not going to be important. So I think that as we think about the future, it's going to be a much more informed way of doing diagnostics. Now, we had an earlier question about resistance. And I'm going to link that together with, we can look at certain organisms and know that if you looked at, I'm trying to think of a good example. If you look at all E. coli as an example, some E. coli have genes that are going to cause gastroenteritis, and other E. coli don't, and they live very happily in the intestines. So if we had a test to be able to say, this E. coli is there, it has this resistance gene, and we know, in fact, it has other virulence markers that make it even more important for causing an infection, that's going to be quite useful. I think that's going to come from doing whole genome sequencing. And you could also link that together with saying, we also now have information about whether that particular bacterium caused infections, not just in this patient, but in the patient in the bed next to them. So I think we're going to start linking together public health aspects of what we'd like to do in the microbiology laboratory with the diagnostic aspects and treatment aspects and put it all together in an important test. And I think that'll be through using things like whole genome sequencing. Now, when I was at the NIH, we used whole genome sequencing for epidemiology, looking at hospital outbreaks. Today, there's another example of using whole genome sequencing, and that's with our SARS coronavirus, being able to identify variants. So if I look towards the future and was going to pick one thing, it probably would be whole genome sequencing, and it may be to be able to look at a clinical specimen and do that for all of the organisms there. And if that's the case, then we won't need these multiplex assays anymore. We'll have a different approach for diagnosis. Sort of a long-winded answer, I apologize, but maybe it illustrates one thing I think is very important is molecular diagnostics are going to be with us and much more important for diagnostics in the future.
Buenísimo, muchas gracias. Acá tenemos preguntas. Ana Tonieri pregunta si el panel vaginal incorporará ureaplasma y micoplasma de interés diagnóstico.
No. We're sort of limited in the number of analytes we can look for. That particular test is very complex because it's also a quantitative test. We measure actually the numbers of organisms and compare ratios. So it's not just, are certain organisms there, but what's the ratio of those organisms? But you've identified what I think are important pathogens, at least the Mycoplasma genitalium and possibly Mycoplasma hominis are important organisms. They're also associated with resistance. Ureaplasma is sort of unique. I'll put that over to the side for a second. I can see that we will develop tests for the mycoplasmas and resistance markers. Those are, in our development discussions. Ureaplasma, again, is sort of different because not all ureaplasmas are created equal, and we think there is a subset that cause disease and the others don't cause disease. So that may be one of those pathogens where sequencing the whole genome actually will identify, is this important or not? So your question is a little bit more complex maybe than how it was posed.
Acá aclara también Ana si tampoco vamos a tener para Mycoplasma genitalium.
Sorry, I didn't understand the question.
Si también vamos a tener un panel para incorporar los ureaplasmas y micoplasmas, incluyendo el Mycoplasma genitalium.
So that panel is in discussions. I know there's been some development work. I'm not sure when it would be launched. I think maybe the other thing to understand is that, and BD is not unique here. What we recognize is to develop these panels is complex. And so if it's done just internally, if it's just BD developing their panels, it's going to be a very long process. What you want to be able to do is to partner with other companies that will help you develop tests. And a good example of that was the COVID-19 test that we launched. We launched one test that was only in Europe, and we launched two other tests that are in the US and globally. The European test was developed by a European partner that we have. And the US test, one was developed internally and one was developed by a partner. So to your question, I know we've been working on the Mycoplasma test. But I know we also talked to partners to see if they would be able to develop faster than what we can do.
Ojalá. Tenemos acá también una Lorena Contreras que levantó la mano. El micrófono a Lorena, por favor. Yo no veo si le dan micrófono.
Maybe while we're waiting for the question, I can pose something. The unique aspect of the BD Max is that we can help you develop your own test internally. And when the Max was launched initially in Europe, we formed a community, much like what you're doing now. And that community helped each other develop their own tests. And so we had a number of tests that we could not take to the FDA or to the Europe group for regulatory approval, but the individual labs could develop the test, validate it for their patient population, and use it. And again, that may be of interest to this community. I think that should be a discussion. And it may be that you can partner together to develop tests that you have a common interest in. Again, recognizing, and this is the reason I qualified some of my comments about the enteric panels. You have some unique enteric pathogens that we don't see globally, or at least not with any frequency. And so it would, from a business perspective, we wouldn't be able to develop those tests. On the other hand, it may be of interest to you, and we have experts in our research and development group that can help you with that test development. So again, something to consider for maybe the more academically oriented hospitals to be able to develop some of the tests that fit gaps that we currently have. And that's one of the unique aspects of the BD Max. It was designed for doing that sort of development.
Exacto. Acá tengo otra pregunta, doctor. Mientras le dan micrófono a Lorena, acá Flavia Malfa pregunta, ¿considera importante buscar colonización por Staphylococcus aureus Methicillin sensible y no solo por Staphylococcus aureus Methicillin resistente?
Yeah, that's in my mind, I think that's a difficult question. First of all, for resistant organisms, this is a general comment, and it's not my comment. I actually read it in a review earlier. This came from the US CDC, so it has some credibility. They were talking about, in general, infections with antibiotic-resistant organisms compared to an antibiotic-susceptible organism. The pathology, or the trying to think of the right word for it, they cause the same type of disease. If it's an antibiotic-resistant organism, it doesn't cause a worse disease. It causes the same disease as a susceptible one. The difference is treatment. For the antibiotic-resistant infections, they're harder to treat because you have fewer antibiotics that you can use. So we'll keep that there. Now, the question about MRSA. What we see now is that more than half of the Staph aureus infections in the hospital are MRSA. So we could argue, do we really need to screen for methicillin resistant, or do we just treat everybody as if they have a methicillin resistant Staph aureus? And I know some people have taken that approach. No screening, just treat more aggressively. The difficulty is that we've selected now for vancomycin-resistant organisms, because vancomycin is a drug we use to treat these infections, and in most cases. And so now we see an increased number of vancomycin-resistant enterococci. So I do think there's value in looking for MRSA in the population. Now, the second part of your question is there value in looking for methicillin susceptible Staph aureus? And again, I would say there's value where there's a risk that Staph aureus can cause an infection. And so you have, as an example, patients having cardiac surgery. Now, that's considered clean surgery, so the risk of infection is low. But a Staph aureus infection in those patients is absolutely devastating. So there is a subset of patients where pre-screening for either MRSA or Staph aureus, or susceptible Staph aureus, becomes really important. And that was the logic of developing the Staph SR test. And there was a paper that was published by Chapin, and it was either in 2020 or 2019, I think it was 2020, that looked at their experience in a Boston hospital with screening for Staph aureus colonization. And what they found, they had a significant improvement in decreasing the number of infections with Staph aureus in their surgical patients. So they did pre-screening surgery. So again, a long answer, but there's advantages in looking for MRSA in general to decrease the amount of vancomycin used, and there's an advantage for looking for any Staph aureus in certain specific patients. So you don't use it for everybody, you use it selectively where it provides value.
Perfecto, muy claro, doctor. Aquí tenemos un comentario, excelente presentación. Por aquí también había un comentario que decía que es todo muy interesante. Creo que Lorena Contreras nos está abriendo el micrófono, me dicen. Doctor, no, el doctor, no. Lorena Contreras, ¿querés hacer la pregunta que levantaste la mano? Ahora le van a dar micrófono. Tenés que abrir tu micrófono, Lorena, para que se te escuche.
Hola, ¿ahí me escuchan?
Sí, perfecto.
Ah, porque no me funcionaba recién. Disculpa, I'm sorry. Bueno, agradecerle al doctor por la presentación, al doctor Murray, que es muy claro. Y bueno, quería preguntar con respecto al panel de vaginal, en el caso de si está pensado para hacer toda la detección de cándidas, porque nosotros todavía, estamos recién empezando como usuarios de BD+, y no sabemos qué experiencia ha habido en los aislamientos de cándidas cruce y glabrata y otras cándidas que tienen por ahí un poquito más de resistencia que albicans. ¿Cuál había sido la experiencia de ustedes?
Yes, the test, and again, because of time, I simplified some things. But one of the advantages of that particular test is it identifies the Candida species that we experience increased resistance. Candida glabrata is an example of that. And so that is an advantage of this particular test because it can help guide specific treatment for candidiasis, one of the 3 groups of vaginal infections that the assay is developed for. So very good question, because it is something that our group should be aware of, is that resistance does exist with some of the Candida species.
Bien. Doctora, acá tengo otra pregunta de Rosaura Taboada. Dice, en el panel respiratorio, ¿está incluida la prueba para Mycobacterium tuberculosis o atípicas? Muchas gracias. Bueno.
I didn't get the translation.
puedo contestarla yo, sino la pregunta es si en el panel respiratorio está incluida la prueba para Mycobacterium tuberculosis o atípicos.
I'm not hearing the translation. and I don't know Spanish.
No, no hay problema. Yo le puedo contestar, es el Mycobacterium tuberculosis complex el que detecta. No detecta atípicas.
All right, so now our translator is awake.
¿No me están traduciendo, doctor? Entonces, they are not translating for you, so I can. Right.
The multi-drug resistant Mycobacterium tuberculosis panel is, as the name implies, it detects Mycobacterium tuberculosis complex. So the species in that complex, and tuberculosis is the most common species, but all the species in the complex are detected. It does not detect the other mycobacterial species like Avium kansasii or the rapid grower species. From my perspective, I had unsuccessfully, I had pushed that the test should include a target for all mycobacterial species. So you'd be able to say, yes, the patient has a mycobacterial infection, and yes, it's Mycobacterium tuberculosis, or no, it's not Mycobacterium tuberculosis, it's some other species. But I didn't win that argument. That's not the test that we have today. I'm not sure if that test is going to be developed. Again, I can see some value for it, but I don't think that's going to get developed, at least not by us. Again, that's my challenge. If that's important for your hospital, maybe we should help you develop that test.
Bien. Y aquí hay otra pregunta, doctor. Quisiera saber si hay inhibidores en las muestras o antibióticos que puedan interferir en el panel respiratorio de Mycobacterium tuberculosis.
With all tests, with all molecular tests, as I think everybody in this group understands, there are inhibitors that can be present in the clinical specimen. It's obviously much more difficult testing specimens than it is testing isolates that are in pure growth. And I have to confess, because I haven't gone back and looked at the testing that's been done to identify what inhibitors may cause problems. Non-reactivity for the test is relatively low. And again, I don't work with this directly, so I'm a little bit vague in percent. Certainly it's less than 5%, but I don't know exactly what it is. And I don't know exactly what inhibitors cause problems. But if you look at the data that was submitted to the FDA, which is on the FDA website, there's a very comprehensive table of all of the both organisms that were tested to show that it's specific, as well as looking for inhibitors and whether or not they created problems. So again, either the package insert or the FDA website can provide you with what I think would be probably a pretty good answer to your question.
Sí, exacto. Está en el inserto para el usuario, que pueden leerlo ahí. Así que si alguno lo necesita, se lo puedo compartir más tarde por correo, me avisan. Y después estaba el doctor Pagela, que creo que ahora sí podía hablar. No sé si el doctor Pagela sigue estando disponible y le pueden dar micrófono.
El micrófono no me han dado. Buenas tardes. Bueno, felicito al doctor por la exposición, como siempre, un lujo sentirlo. No, yo quería hacerle una pregunta con respecto, siguiendo lo que había preguntado recién Lorena, con respecto al panel de cándidas, si se detecta Candida auris.
No, Candida auris is not detected. Again, for what we're referring to there is the vaginal panel. And so the focus obviously is on vaginal pathogens. Candida auris, as I think most of our
sería para una candidemia, una candidiosis sería a lo cual yo
the test was not designed for that. It's designed for using vaginal specimens. Now, should we have a panel that can identify that? Maybe. I think that's, I'm trying to think how to say, if you have a panel to identify, let's say, organisms isolated in positive blood cultures, that's going to be a very large multiplex panel. And we see commercial panels that are designed to do that. From my perspective, we don't need a molecular panel to do that. We can do that with MALDI or alternative tests for identifying that organism. But we don't at this time have any tests to identify Candida auris.
Déjeme agregar,
Muchas gracias, doctor.
quiero agregar para responder al doctor Pagela. Hay varios trabajos publicados usando el sistema abierto. Justamente hay uno muy reciente de la doctora Susan Silbert del Hospital de Tampa, que tiene un equipo y tiene muchísimos trabajos en el sistema abierto. Publicó un trabajo para detección de Candida auris. Simplemente pueden entrar a las páginas de buscadores de trabajos científicos y poner BDMAX y el microorganismo que ustedes estén queriendo identificar, y tal vez encontramos un trabajo que lo haya desarrollado y podemos contactar al autor y ver la posibilidad de validarlo en su laboratorio.
So maybe let me make a comment. She's been very, very much involved in assay development and evaluation for the BD Max. And Suzanne is, I think, an excellent collaborator. And I am certain that if you reached out to her, she would be very helpful in helping you develop those tests. I know she's spoken to Max users in a number of different settings, and I'm sure she would be helpful for you.
Así es, gracias. Acá me parece que hay otra pregunta. ¿Está en desarrollo algún test para Mycobacterium? Ya lo contestó el doctor, me parece. Sí, atípica, no tuberculosas. Ya lo contestó el doctor hace un ratito. Bueno, no sé, ¿hay alguna otra pregunta? ¿Alguien que quiere hacer algún comentario?
Sí, si me permite, tal vez no había escuchado, tal vez no escuché, pero para el panel de COVID, ¿las variantes son detectadas?
Now, I'm surprised it took that long to ask that question. And so we deal with that question for both our molecular test, the MAX test, and the 3 variations of the MAX test that we've developed, as well as with our point of care Veritor test. And one very important aspect for the MAX assay is that what you want to be able to do is to develop an assay against multiple gene targets. And they've done that with the MAX assay, with actually all 3 of the MAX assays that have been developed. And interestingly, the most common test is against the genes for N1 and N2 in the nuclear capsid protein region. That's the area where we see a lower number of mutations. Most of the mutations in the variants that are causing concern are in variants that have mutations primarily in the spike protein. So that's really more of a concern for maybe some of the other types of assays. If you have multiple targets, then the chance of having mutations in all of those targets is decreased. So in theory, we would say that the max assays should still detect the variants of the coronavirus. That's all well and nice, but what's the proof? So what they've done first is and this work has been done very nicely by a number of investigators, they've mapped out where all the mutations are. So in silico, or in the laboratory, you can actually reconstruct that virus, look at where your target genes are for the max assay, and ask, does it affect that target gene? And by in silico testing, the answer is no. And that's true for the 5 major variants that are circulating right now that we're most concerned about. And that includes B1. What we then did is we contract with a laboratory that's able to get these strains of virus and actually do direct testing with the max assay. And currently, all of the variants that we've seen that are of concern are detected with the max assay. That's not to say that there won't be strains or variants that will occur. We just haven't seen them yet. And that's, again, the challenge for all of the molecular tests. And that's the reason why, again, having multiple targets become important.
Thank you very much, Mr. Doctor.
Muy bien. Aquí hay una última pregunta porque deberíamos ir cerrando. Ya estamos en tiempo. Lorena comenta que en Argentina es muy importante la carbapenemasa OXA 163. Si estaba pensado agregarla al panel. Yo ya le puedo adelantar de que está incluida en el panel a Lorena, pero bueno, doctor, usted si quiere responderle, adelante.
No, I think, when we talk about, this is a good point. When we talk about detecting the 5 most common carbapenemase genes, we recognize that, again, there are variations of those genes that occur over time. And we try to monitor that as best we can to make sure that our assay detects all of the variants of those carbapenemase genes. Having said that, we do recognize that there are gaps that are discovered. And sometimes we can fix that, and other times it's not something that we're able to fix because we just can't add more targets to our gene assay. But when we refer to the OXA target, it detects a number of those variants. I can't, and probably Gabriella would be better at answering this question to tell you how many variants of OXA, but it detects a number of these variants. It's a good question, though.
Sí, claro. Como nosotros estamos acá viviendo en Argentina y sabemos cuál es la carbapenemasa que circula con mayor frecuencia, es una pregunta muy común. Así que sí, yo verifiqué que está dentro de los tipos de OXA que están incluidos y que son detectados. O sea, no te va a decir qué es la 163, pero sí la va a detectar. ¿Sí? O sea, no te la identifica especialmente, pero va a decir que hay una OXA, OXA-like en la muestra. Bueno, si no hay más preguntas, y la verdad es que, quería agradecerle al doctor infinitamente por haberse conectado hoy, por darnos esta posibilidad de conversar así, cara a cara, como tenerlo en el living al doctor, es un placer. Espero que lo hayan disfrutado como yo lo disfruté. Thank you very much, Dr. Murray. I'm so pleased that you've been here.
Solo aprovechando ahí, Gaby, también para agradecer a todos de verdad la presencia. Y Pat, thank you very much again, my friend. It's always nice to see you, to hear you. We always learn a lot with you. Y para todo el grupo, de verdad que esto sea la primera de muchas juntas. Vi que hay todavía muchas preguntas aquí Creo que en los próximos eventos vamos a poder contestar más. Reservamos más tiempo, ¿no? Gracias, Gaby, gracias a todos y de verdad un excelente evento. Buenas noches a todos.
Gracias a todos, buenas tardes, buenas noches y esperemos encontrarnos en otra oportunidad muy pronto. Chao.